Hi, everyone. I'm really excited to introduce our next speaker for this talk because this is something I have questions about on a near constant basis. So we are going to hear about tuberculosis in 2025 from Dr. Pinkney, who is an infectious disease doctor here at MGH. Dr. Pinkney?
Hi, thank you so much for having me. I'm super excited to be here today to speak to you about tuberculosis in 2025. Of note, I have no relevant disclosures. And the learning objectives for today, by the end of this session, I'm hoping that all participants will be able to understand the natural history, microbiology, and pathophysiology of TB. We'll be able to recognize the epidemiological, clinical, and radiographic features that raise suspicion for active TB. We should be able to differentiate the difference between latent, active, and subclinical TB, and then select, understand, and interpret the appropriate diagnostic methods for TB. And of course, we should all know the lifeline, who to call when we have questions, so we should know the support resources. So starting with the history, TB was first discovered on March 24th, 1882 by Robert Koch, who's a German physicist. And now, March 24th is World TB Day around the globe. Around 25% of the world's population is infected with the tuberculosis bacterium, and you can see on the graph the areas that have a deeper intensity of green are the more affected regions. In 2023, approximately 1.2 million people died from TB, including 160,000 people with HIV. And the CDC estimates that around 13 million people in the United States have latent TB infection. Without treatment, around 5 to 10% of those will actually end up to evolve to developing active TB disease over their lifetime. And this is a very nice schematic from the World Health Organization that kind of tells us the high burden TB countries, and it groups it into 3 different groups by color code. So regions that have a high prevalence of TB and HIV co-infection in yellow, countries that have a high burden of multi-drug resistant or rifampin resistant tuberculosis in blue, and then countries that have just a high burden of TB in red. And so you can see there's significant overlap. The only country that's not having an overlap of these 3 conditions is Sierra Leone. That is just a high TB prevalence country, but the others, there is a high overlap between both the high burden of TB and the high burden of multi-drug resistant or rifampin resistant TB, including countries like China, Brazil, the Ukraine. Globally, we are on a pathway to end the TB epidemic by the year 2030. It is among the United Nations Sustainable Developmental Goals. And the way that we can do this is by detecting cases and treating cases of latent TB to stop the progression to tuberculosis. So that is our aim. Whether or not we will make this goal, we will see. I'm hoping that with increased awareness, we can. So going down to the microbiology of TB, because this is very important for us to understand how things have evolved over time. So tuberculosis is a member of the complex of closely related mycobacteria. And you can see in the diagram here that it split off from the non-tuberculous mycobacterium several million years ago. So you have the environmental mycobacteria like Mycobacterium avium complex, which you just heard about, or MAC. And then it split into the mycobacteria affecting humans, or the mycobacterium complex. Of those, it consists of Mycobacterium tuberculosis subspecies, which has 7 lineages. But it also consists of Mycobacterium bovis and Mycobacterium bovis BCG, that's in the BCG vaccine. It also has Mycobacterium africanum, which is in West Africa. In cultures, when a lab identifies Mycobacterium complex in cultures, they're identifying the whole complex. So it could either be Mycobacterium tuberculosis, subspecies tuberculosis, or it could be one of these other mycobacterium in the Mycobacterium complex. One quick trick to differentiate whether it's Mycobacterium bovis or Mycobacterium bovis from the BCG is that pyrazinamide, resistance is intrinsic to Mycobacterium bovis and Mycobacterium bovis BCG, whereas it is not for Mycobacterium tuberculosis. So that's just one quick thing. In terms of the pathogenesis of TB, it is highly dependent on two things: the host immune response system and the mycobacterial specific characteristics. So the mycobacterium specific characteristics, it is a bacillus. It is very slow growing. It actually takes 20 hours for it to replicate itself. So for one to turn into two, it takes 20 hours. And so visible growth on solid media usually takes anywhere between 3 weeks to 8 weeks. And why is this? That's because it has a very complicated cell wall structure. So in addition to the peptidoglycan layer, which we can see in most bacteria, it has these two additional molecules. The first one is the arabinogalactan layer, followed by the mycolic acid layer. And you can see this is extremely thick, and this is helping to create a barrier to penetration, specifically for antibiotics and nutrients. This is also responsible for giving the mycobacteria its acid-fast stain. The lipoarabinomannan glycolipid here, or LAM, is one of the things that can be detected in the urine of patients with tuberculosis and can be used to diagnose it in other countries. It's not a test that is validated in the US. But overall, this very complex, very thick cell wall helps the mycobacteria to evade the body's immune system. It helps also with intracellular survival of this mycobacteria, granuloma formation, and immune manipulation. So what happens once the mycobacteria enters the lung? Your first line of defense or innate response is the alveolar macrophage. So the macrophage is going to engulf the mycobacteria or phagocytosis. And when it engulfs it, usually what happens is that this phagosome fuses with a lysosome and that digests the mycobacteria, right? However, TB has evolved to the point where it's resistant to fusing with the lysosome, and so it gets to survive intracellularly. The next line of defense is the alveolar macrophage. It's crying out for help. It's saying, oh, I'm infected and I can't get this thing out of me. I need some backup. So it's signaling the release of cytokines such as interleukin-12 and tumor necrosis factor to recruit more immune system cells, mainly natural killer cells, eosinophils, dendritic cells. And these natural killer cells and some of the macrophages will then start to produce interferon gamma to try and control the infection. Interferon gamma is very important in activating the lysozymes and promoting fusion of the lysozyme and the phagosome, ultimately to destroy these intracellular bacteria. So afterwards, these alveolar macrophages migrate from the alveolar space into the lung interstitium, where they're picked up by the lymphatics and carried to the lymph nodes. In the lymph nodes, they then activate or prime your T cells, specifically your CD4 T cells become activated into T helper cells, and that produces even more interferon gamma. This interferon gamma activates more macrophages, activates more T cells, and as I said, the interferon gamma is very important for the fusion of the phagosome with the lysosome to help destroy these intercellular organisms. Interferon gamma also promotes the production of nitrogen and reactive oxygen species within these activated macrophages to promote the death of the mycobacteria. You also have granuloma formation. So here is a granuloma with the mycobacteria inside these macrophages at the center, as the immune system tries to wall off or contain this infection. The granuloma is surrounded by macrophages and giant epithelial soils, which are just basically macrophages that have joined up together. And then that's surrounded by T cells. And that is your granuloma. I also want to note at this point that the Mycobacterium genome in itself has two areas specific, and this is the Mycobacterium tuberculosis subspecies. The two areas are the ESAT, or early secreted antigen target, and that helps to stimulate and activate CD4 cells. And then you also have the culture filtrate protein, and that also works to stimulate T cells to produce interferon gamma. And I will note that this part of the genome is lacking in Mycobacterium bovis, or Mycobacterium bovis BCG. And that's important when we think about the interferon gamma release assays that we test for, because a lot of people think that they are affected by the BCG vaccine, but just to note that this is missing from that genome. So in terms of the virulence of TB, it is dependent on host-specific factors. As you can imagine, if someone has an inborn error in their interferon gamma, they're not able to fight the infection or contain the infection, as well as someone who has a normally functioning interferon gamma. And specifically, there's a condition, or Mendelian susceptibility to a mycobacterial disease, which is a genetic error of that interferon gamma. You also have tumor necrosis factor mutations that can lead to increased susceptibility to mycobacteria. And then for the mycobacteria itself, there are specific lineages that are more virulent than others. So for instance, the L2 lineage, or the Beijing strain, is considered hypervirulent, harder to control by the immune system, and leads to more severe disease. In terms of the transmission, most commonly, tuberculosis is transmitted via aerosolized droplets, which are generated when a person with the disease involving the airways or the lungs starts talking or coughing. The uninfected or susceptible person then inhales those droplets and leads to 4 different outcomes. So once you inhale it, you can either, one, have really, really good alveolar macrophages that can actually clear this infection. That occurs in around 5% of people that are exposed that don't end up getting mycobacterial infection at all. Around 5% of people will go on to actually develop primary pulmonary TB at the time of exposure. But more often than not, 90 to 95% of people will go on to develop latent tuberculosis, where the TB is contained within that granuloma and not able to spread or cause disease. And then around 5 to 10% of people will develop reactivation of TB disease, or active TB. There's also the term miliary TB, which occurs when there is massive lymphomatogenous spread of the TB. Remember, I said once it leaves the alveoli, it goes to the lymph node. And what can happen is that a lymph node can rupture into a blood vessel, which leads to its basically sepsis or bacteremia, and transport to various organs in the body, including the brain, the lung, the kidneys. That syndrome presents with several weeks of fever, anorexia, weight loss, and cough. Very rarely, it can present without a fever as a progressive wasting syndrome that kind of mimics metastatic cancer. And if it presents like that, the terminology is cryptic miliary tuberculosis. And this is just a schematic of it, where you have extrapulmonary spread. It can go to the pleural space and cause pleural tuberculosis. It can also go to the intestines, causing intestinal tuberculosis, spinal TB or POTS, genitourinary TB, and as in another case, tuberculosis lymphadenitis. The clinical spectrum here, represented here, does come with different test results, and I will leave this for later on. But essentially, once you've inhaled this mycobacteria and you control it, and you have latent TB, you expect your tuberculin skin test and your interferon gamma test to be positive, but because you're asymptomatic, you don't expect to have any other positive test. Moving from latent TB, there is an entity called subclinical tuberculosis, where there is some containment of the bacteria in the granuloma, but a few have escaped. It's not leading to rip-roaring active disease, so it's somewhere in the middle. People at risk of developing TB disease fall into two broad categories, and that is people who are continuously exposed or have a high risk of exposure, and that includes people that are born in one of those high endemic TB countries. It also includes people that live in large group settings where TB is more common, such as people that are homeless or people living in shelters. It also includes people that work in areas where TB is more likely to spread, such as those that are working in hospitals or working in correctional facilities or nursing homes. The second bucket of people at increased risk of TB are those with a weak immune system. We just saw how important the immune system is in containing the tuberculosis bacteria. So babies or young children who haven't had a fully formed immune system are particularly vulnerable to TB. You also have people with HIV who have a low CD4 or T cell that would be at high risk, people on immunosuppressants. The groups that are, I think we don't think about often that are also at increased risk include people with severe kidney disease or end-stage renal disease, persons with diabetes, or people on steroids. So let us look at a case. So we have a case here of a 54-year-old Spanish-speaking man from the Dominican Republic who has a past medical history of retinitis pigmentosa. He's legally blind. He also has diabetes, hypertension, high cholesterol, and shoulder pain. In 2022, he had a positive quantiferon test. He was seen by a pulmonologist and didn't have any respiratory symptoms at all. So he was assessed as having latent tuberculosis, but declined the latent TB treatment because he attributed his positive test to the BCG vaccine. Skip forward in time to February 2024, his diabetes is now way out of control. He has an A1C of 15. And in addition to this, he's developed this painless left neck mass. They do some imaging. It shows a complex cyst in the submandibular area, an extensive cervical lymphadenopathy. They end up doing a left modified radical neck dissection because they were concerned about a malignancy. To their surprise, the path came back with necrotizing granulomas. The acid-fast bacillus stain was negative, but the cultures came back positive for Mycobacterium tuberculosis. At which point he did a chest x-ray, which was clear, and he was referred to our ID clinic for management of submandibular gland tuberculosis. And I think this should raise some questions. So based on the presentation, some of the questions I had was, what type of TB is this? Is it really just submandibular gland or cervical lymphadenopathy? Not sure. The second question was, had it been surgically cured? He just had an excisional removal of the lymph nodes in the neck. So is there any TB remaining? And so what would be your next steps? The other question was, would you classify this as extrapulmonary TB or pulmonary TB or miliary TB? Is it latent? Is it active? Is it subclinical? And do you want some more diagnostics or do you want to just start treatment? Well, what did I do? I got a PET scan because one, I wanted to know, was there any residual evidence of disease in the neck after this extensive radical neck dissection? And in fact, there was. He did have an FDG avid lesion in the cervical region and supraclavicular region. He also had these scattered, very highly FDG intense clustered nodules in the right lobe of the lung. Now, remember, his chest X-ray was completely normal. This would have been missed by his chest X-ray, but it did light up on his PET CT. And when we ended up doing just a regular CT chest, he had several of these nodules and tree and bud pattern on the right lung. So based on the new information we had, does that kind of clarify what type of tuberculosis he has? I would say no, it hasn't been surgically cured because we're still seeing residual disease in the neck and we're seeing now disease in the lungs as well. And what are your next steps? Do you want more diagnostics or do you think you have enough information to start treatment? In my case, I definitely wanted some sputum, right? He has this FDG avid lesions in the lung. And even though he's not having a cough or any shortness of breath or any hemoptysis, it's a public health risk if he actually does have tuberculosis growing from the lung. So we sent him for induced sputum, and what happens to your specimen once it goes to the lab, we'll start from the left side of the screen. First, they do a smear or an AFB smear, which is an auramine rhodamine smear, where they look at the sputum with this stain, a fluorescent stain. And if mycobacteria is present, it will appear bright yellow, as bright yellow bacilli. If the smear is negative, or sometimes even if the smear is positive, we can go on to do a Mycobacterium tuberculosis PCR test. That PCR test is actually very sensitive. So around 59% of people that have a negative smear but a positive culture will be picked up with the TB PCR test. It's a real-time assay. And the other benefit of it is that it can also detect rifampin resistance at the same time. So, So after the TB PCR, if that's negative, you go on to put it in a liquid media culture. And this is basically a very enriched culture that has a lot of nutrients that the mycobacteria likes. It's then monitored for oxygen consumption. And if mycobacteria is growing and it's consuming a lot of oxygen, the machine will detect it and alert the technicians that they need to check it for mycobacteria. So in this case, it alerted us. We then took a sample from this liquid media, put it on a slide, and stained it with a Ziehl-Neelsen stain. That stain is a pink stain, and it can look like cords because the mycobacteria has this thing called cord factor that helps it to clump together. So it was detected with the Ziehl-Neelsen stain. Then it is put onto a Lowenstein-Jensen culture media where it's left to grow. And because Mycobacteria tuberculosis is one of the reportable diseases, all of the samples have to be sent to the state lab, who does susceptibility testing to tell us which antibiotics will work against it. And then it's also sent to the CDC for whole genome sequencing, which helps us to figure out, one, that it is Mycobacterium tuberculosis subspecies tuberculosis, or it can tell us it is another one of those in the complex, such as bovis or africana. So at MGH, or Mass General Hospital, the only specimen types that are approved for Mycobacterium PCR are sputum and the bronchiolar alveolar lavage, or BAL samples. The other specimen types, such as pleural fluid or a lung biopsy, has to be sent out to the Mayo Clinic. But they are available to have this PCR done if you need. The rifampin resistance information is not routinely reported, but because this can give us an answer, it's available upon request. The multi-drug resistant TB PCR is not yet available in the US. Whole genome sequencing helps the CDC to identify clusters or outbreaks because it can tell which group of TB are the same or who the source patient was for an outbreak. And then there's also molecular beacon testing, which uses DNA sequencing to detect mutations for the most common TB drugs that we use, as well as the newer agents like bedaquiline, clofazimine, or linezolid. In terms of treatment for tuberculosis, It's usually divided into a intensive phase and a continuation phase. The intensive phase is usually made up of 4 drugs for a duration of 8 weeks. And everyone kind of remembers the acronym RIPE, which is rifampin, isoniazid, pyrazinamide, and ethambutol. However, this, of course, will depend on the susceptibilities and the region that the person is from. The continuation phase is usually consists of 2 active drugs, and that is continued for 18 weeks. Fresh off the press, we have some updated guidelines as of 2025, updates in treatment of drug-susceptible and drug-resistant tuberculosis. And they have introduced a shortened course for isoniazid susceptible and rifampin susceptible TB. So instead of doing 6 months, which is the initial thing presented, you can have a 4-month regimen of rifampicin, isoniazid, pyrazinamide, and moxifloxacin. They also have recommendations for rifampin-resistant regimens, including the use of bedaquiline, pertomidine, and linezolid. All right, let us go to the second case. So we have a 28-year-old female who is a physician. She experienced an unmasked TB exposure to a patient during one of her rotations. And subsequently, this is now 2.5 months later, she gets a call from occupational health that she's been exposed. She needs to get her T-spot checked, and so she got her T-spot checked, and it's positive. So then she's sent for a chest X-ray. Her chest X-ray is negative, and she has been asymptomatic. She's not been having any cough, any fever, any weight loss. Her past medical history, she has a history of anxiety. At the beginning of her employment, occupational health had done a TB screen that was negative at the start of her residency. She had also done an HIV test a year before for a needle stick injury, and that was negative. She doesn't have a history of using steroids or biologics. She's had limited exposure to homeless populations because of volunteer work that she does. She was born in the US, has only traveled to Cayman, Mexico, and Australia. So based on this history, once again, how would you classify this patient? Would you classify her as having latent, active, or subclinical tuberculosis? What additional history may you want before you offer her treatment or not offer her treatment? And if you do offer her treatment, what agent would you use? So once again, just wanted to go over the fact that the Mycobacterium tuberculosis, subspecies tuberculosis, is the only one that has these 2 antigens. And I'm going to explain how the interferon gamma release assay works. So there are 2 interferon gamma release assays that are commercially available in the US. There's the quantiferon TB Gold, and there's the T-spot TB test. Both of them use the patient's white cells. So once you give your blood sample, that's separated where you have the white cells isolated. These white cells are then added to a well that has antibodies against interferon. The well is, so purple cells here are the white cells, and then they've added ESAT and CFP, which is the little black stars. And that stimulates the white cell to start releasing interferon gamma, which is now here in green. Once the interferon gamma binds to the antibodies in the well, then they can use a conjugated antibody to basically detect bound interferon gamma. And this shows up as little spots or loculations in the well. And that's the last slide. So they read, when you see the report for an interferon gamma or a T-spot, it can say how many spots, if they're seeing 16, 8, etc. It doesn't really matter how many spots they're seeing. If it is positive, then you know that they have been exposed to TB specifically in the past because their white cells are primed to release interferon when exposed to ESAT and CFP antigens. So this is just a summary of the different types of tests. So the quantiferon test, the processing time is around 16 hours, similar to the T-spot where the processing time is around 8 to 32 hours. And if you compare that to the tuberculin skin test, that's very time efficient because the tuberculin skin test, you inject this tuberculin mix and then you read it 48 to 72 hours later. The tuberculin skin test, unlike the T-spot and the quantiferon that has very specific antigens, is actually made up of a mix of over 200 proteins killed from tuberculosis. And some of those overlap with the proteins or antigens found in Mycobacterium bovis BCG, which is why many people with the BCG vaccine can have a positive tuberculin skin test. Possible results for the quantiferon and the T-spot include positive, negative, borderline, or indeterminate. They're about 91 to 90% sensitive and 97 to 98% specific, whereas the tuberculin skin test is around 95 to 90%, 75 to 90% sensitive. One thing that can help you to counsel the patient about their risk of developing TB once they have a positive tuberculin skin test or a positive interferon gamma release assay test is this risk tool or online interpreter. And based on the information you put in, which asks about the country that they were born in, their test results, their TB exposures, as well as any immunosuppressive conditions they may have, they give you a score, and the output looks like this, where you can say, for instance, a gentleman that was born in the Dominican Republic who had the BCG vaccine but has an abnormal chest X-ray, has an abnormal, has high diabetes, has an annual risk of developing TB of around 2%, and a cumulative risk of developing TB by the age of 80 of 100%. So this would have been something very helpful to help counsel our patient about their risk and kind of advocate for latent TB treatment. And then this is just the tuberculin skin test in terms of how to interpret the various readings. So we have a cutoff of 5 millimeters, 10 millimeters, and 15 millimeters. The lower threshold of 5 millimeters is for people that have an immunosuppressed system. So persons with HIV, we have this lower threshold, or if they're on any of the new biologic agents or corticosteroids. The 10 millimeter cutoff is used for people that are born in high endemic countries, including Asia, Africa, and Latin America. It also includes persons with substance use disorder or people working at, for instance, a hospital where they have increased exposure. And then the 15 millimeter cutoff is for anyone, even if they don't have any risk factors. In terms of the testing algorithm, we usually recommend that if a patient has an illness associated with immune suppression, that you would start using the T-spot rather than the tuberculin skin test. We would also recommend using the T-spot for people that have had a BCG vaccine in the past, just because there's no cross-reactivity. Now, UpToDate gives you a very nice algorithm as to what to do if you, for instance, get an intermediate interferon gamma release assay, which can happen sometimes, or a borderline T-spot. The recommendation is that you repeat this test, so you can either repeat the quantiferon or repeat the T-spot. If it is continuously indeterminate, you can check the tuberculin skin test, but that comes with the caveat of whether the person has been vaccinated with the BCG vaccine or not, because once again, the interpretation would differ. Always, if you have a high index of suspicion, meaning someone from a highly endemic country, and they have a borderline test multiple times, it would be better to err on the side that they have been exposed and are eligible for treatment. There are also times when you can have discordance between the tests. For instance, you may have a positive tuberculin skin test, but a negative quantiferin test. And there are some correlations with smoking, undiagnosed diabetes, the BCG vaccine that are predictors of these types of discordant tests. But the most important thing to note is that any positive quantiferin test is associated with a very high risk of actually having TB or having exposure to TB. So it increases the chance that you'd have a positive TB test by 6.3-fold compared to those who have a negative quantiferin test. If you have a positive quantiferin and a positive tuberculin skin test, your risk goes up 7.5-fold. So going back to the case of our physician, what was some additional history that I wanted to know? So she was working at a hospital, and the occupational health would have the information on the source patient. So I wanted to know what the source patient's TB was looking like. Because if they were coming, for instance, from an area with very drug-resistant tuberculosis, then the choice of antimicrobial agent that we would offer her would change. And he was, in fact, coming from an area with multi-drug resistant TB. So with that, how would you treat? So there, for latent TB, there are 4 regimens that are usually recommended. You have the shortened regimen of isoniazid rifampin. More common than not, we use 4 months of rifampin or 6 to 9 months of isoniazid. But we should note that patients who reside in a region with isoniazid resistance greater than 7%, or for whom drug susceptibility testing is unavailable, then you should really consider starting with rifampin instead of using isoniazid. And that includes immigrants from Vietnam, Haiti, and the Philippines. The countries with the largest share of rifampin-resistant TB include India, Philippines, and Russia. And so in those cases, even rifampin wouldn't be a good choice for treating their latent TB. You may want to use something like moxifloxacin. Over time, as a global community, we have improved in the number of people we are treating for latent TB. So in 2015, the green portion of the bar is what's represented as the portion of people that we are treating for latent TB. And you can see by 2023, that has significantly increased. So where can you get additional help if you need it? There are tuberculosis centers of excellence in the United States, and they're designated to each region. For the New England region, here in blue, it is the Global TB Institute at Rutgers. And they have an actual webpage that they call TB Consultation, where you can put in the information about your case and the specific question that you need help with. So for instance, if you're not sure if this is really a highly endemic TB area that the patient is coming from, or if the person is coming from a multi-drug resistant TB region, what should you choose? They are very good at being helpful. These are some additional resources. So the CDC has a core curriculum on tuberculosis, what the clinician should know. That's extremely helpful. And the World Health Organization also has several sources that are helpful to go through the different modules on tuberculosis. So in summary, we should all be able to recognize the epidemiological, clinical, and radiographic risk factors for active tuberculosis. Hopefully by the end, we now can differentiate between latent, active, and subclinical TB and understand these different diagnostic tests and what influences these tests, including that the BCG vaccine does not affect the T-spot and quantiferin tests, which we get a lot of, and also knowing the importance of the epidemiologic history, given the rifampin or isoniazid resistance can really change your management. Thank you.